All right, looks like we are recording now, so you can post your name in the chat. So there's history of your name in the chat log. And while everyone's signing in, does anyone have any questions at all about the course so far? I know some people had messaged me asking about those Evolve modules. Those are just supplemental resources for you that were put in the course from prior instructors. I'm not sure if they're still active. They're there if you want them. If not, don't worry about it. It's just some extra stuff for you to review, but they're definitely not assignments, okay? So if they don't open up, don't worry about it. Any questions on anything before we start a skeletal system? You can either put it in the chat or you can unmute yourself and let me know. Ask me the question. Okay. Okay, no questions. We'll get right to it. This week is skeletal. So once again, this is just a brief overview of the chapter. You have an extensive amount of information in your pathology book that's covered. I like to focus on, common pathology that we hear about in clinical, that we observe. So I would like to focus on that. First one being spina bifida. Okay. Oh, sorry. Spina bifida, that's the spinal canal defect when the posterior elements don't fuse properly. So basically, that spine and spinal cord are not developing properly in the womb, and the backbone that protects the cord doesn't close completely. You'll see that in that early, if the mother has an ultrasound in the first or second trimester, they'll be able to catch that. Studies say a lack of folic acid early in the pregnancy can be a significant factor. So this is what it's looking like on the backbone there of the baby. This would be a fetal ultrasound at 24 weeks there, showing that protrusion. Spina bifida occulta, which is the most common type, results in a defect of the spinous process or the lamina, usually down in this lower lumbar spine. Okay, no cure for spina bifida. Patients with spina bifida usually have difficulty walking. They'll have some sort of cane or walking device to assist them. Osteopetrosis. Osteopetrosis is nicknamed marble bones because, as you can see here, the bones are very white marble looking. It is a hereditary bone dysplasia where there's a failure of the reabsorptive mechanism, the calcified cartilage, which then interferes with the normal replacement by mature bones. So in turn, it results in very brittle bones. So even though it's looking white there, like it's thick, it's actually brittle bones. And really the only treatment for it is a bone marrow transplant. Patients with this, will get frequent fractures if they fall or get injured. Osteogenesis imperfecta. That's nicknamed brittle bone disease. It's another inherited disorder of connective tissue, which will then cause multiple fractures. There's a defect in the collagen and the osteoblasts, so they're going to fracture very easily. These type of patients have a blue tint to the whites of their eyes and usually a curved spine. Unfortunately, no cure for this pathology, for this disease. Chondroplasia. The most common form of this is dwarfism. These are the short limbs, short arms, short legs, short limbs with a normal axial skeleton. It's resulted from diminished proliferation of the cartilage in the growth plate. So achondroplasia is your dwarfism, shortened limbs. Rheumatoid arthritis. This is a chronic systemic idiopathic disease. A lot of patients with rheumatoid arthritis have other systemic conditions like psoriasis. This is going to appear primarily as a non-infectious inflammatory arthritis of those small joints in the hands and the feet. Osteoarthritis, also known as degenerative joint disease, DJD. Common generalized disorder that's characterized by loss of joint cartilage and reactive new bone formation. You can see this in the knee here. This is part of the wear and tear of aging, and it's going to affect your weight-bearing joints. So this would be patients who are heavy, who are putting a lot of weight on those weight-bearing joints, will usually experience this early on. Bursitis, that's the inflammation of fluid-filled sacs near the joints that reduce friction caused by the movement. This is usually caused from repeated physical activity. So like someone who plays tennis every day. And you can see this clearly with a MRI scan with contrast. Any scans like that that have any of those kind of scans for bursitis in the elbow, shoulder, knee. Osteoporosis. Bones become weak and brittle from aging. A lot of patients after 50 will start having DEXA scans, dual energy X-ray absorption, also known as bone density test, to see if they do have osteoporosis. Ways of kind of reducing the effects of this, no real cure, but to help with the effects of the aging, vitamin D, weight training, exercise to strengthen the bones. Osteomalacia. This is insufficient mineralization for the adult skeleton. The bones are going to soften and weaken and then therefore lead to fractures. May be caused by inadequate calcium or vitamin D. Rickets. This is a systemic disease in infants and childhood, so it's equivalent to the osteomalacia that we just saw in adults, and deficient from vitamin D in the diet or lack of exposure to sunshine. So you see here on the left, image A shows the rickets in the child here. Then after vitamin D therapy, you can see the improvement in the bones. Gout. This is a disorder, the metabolism of purine, which is nucleic acid, so uric acids. It increases uric acid in the blood, which leads to the deposit of uric acid crystals in the joints. It's very common in the first metatarsophalangeal joint, as you see here in this x-ray. Osteochondroma. This is a benign projection of bone with the cartilaginous cap. It arises in childhood or in the teen years near the knee. Osteogenic sarcoma. Sarcoma is a malignant tumor of osteoblasts, which produce osteoids because of calcified bone there. So this one is malignant. Chondrosarcoma, a malignant tumor of the cartilage. Commonly occurs in long bones, but could originate in the rib scapular vertebrae. Ewing sarcoma, another malignant tumor. This one arises in the bone marrow of the long bones in children and young adults. Multiple myeloma. This is a widespread malignancy of plasma cells, and you can see here it destructs the bone there. All bone destruction in this skull from the multiple myeloma. Bone metastasis. This is the most common malignant bone tumor. That means basically there was a primary tumor that spread through the bloodstream or lymphatic vessels, or it had a direct extension that it spread, but you can see here it basically just starts eating the bone away. So, they worry if someone who is diagnosed with breast cancer then's having pain in the back or pain in the hips. You take an x-ray and you start seeing bone deterioration like that, then you could, they'll be going for a PET scan. You could assume it's possibly Mets. All right, let's look at types of fractures. Now, types of fractures is, terms that you would definitely could potentially be asked on the boards here, making sure, you understand the difference from them. Complete fracture, that means you've got two bone fragments now, whereas incomplete, one side of that bone is still intact. Open is a fracture with a skin wound. Okay, compound is going through the skin. Closed is a fracture with the skin and still intact. Transverse is your fracture line on a horizontal axis. Oblique, fracture line extends at an angle to the long axis. Avulsion are small fragments pulled from the bone by the attached ligaments or tendons. Comminuted would be more than two bone fragments. Butterfly is not usually asked. That's just a triangular fragment. Segmental, it's not too much. Compression is your compacts or trabeculi compression fracture. You see that a lot in the spine. Depressed, you would see that like in a skull, where there's a fragment driven inward, a skull fragment pushed into the brain. Spiral is just your fracture line encircling the shaft. Green stick will happen in pediatrics and an immature bone. Buckle is a compaction of one side of the cortex, and bowing is a deformity of the bone. So You could see the illustrations of those different fractures here. That's why it's always good to take a look at your pathology report, your radiologist report after you do an x-ray, a skeletal x-ray, that there is a fracture you see. You always want to read the report to see what type of fracture it was so you can, have more knowledge. Like any pathology. Oh, I see something in this chest x-ray. I'm not quite sure what it is. Read the report afterwards so you can start learning what you're looking at. Battered child syndrome. This is when there's multiple repeated physical induced injuries in young children caused by their parents. For the boards, it's going to be known as SNACT, which stands for suspected non-accidental trauma. That's how they'll refer to it on the boards. Some common fractures that we see a lot in clinical is your Colles fracture, a transverse fracture through the distal radius with posterior angulation. Boxer's fracture, your transverse fracture of the neck of the fifth metacarpal with palmar angulation. That's usually when they've punched a wall, punched something, I should say. Jones fracture, that's transverse fracture of the fifth metatarsal base. And scoliosis here. That's not a fracture anymore, sorry. Moving on to scoliosis, which is your lateral curvature of the spine. That's the difference between kyphosis, lordotic, all those things. Scoliosis, that curve is lateral. Okay, so it's shaped like an S. And last is the spondylolisthesis. Thesis is going to be your forward displacement of one vertebrae on another. So spondylolisthesis is your forward displacement of the vertebrae. So this week's quiz is just on skeletal. I think it's around 20 questions. You can look on the description of it on the weekly module. It will tell you how many points. So if it's 20 points, then it's 20 questions. And it will just be on skeletal that was discussed during this lecture and in these PowerPoints. I'll have the recording up by tomorrow. So when you're taking your notes and studying for your quiz, you can review back to the recording to review the PowerPoints again. Okay. Make
I
sure.
have a question.
Yep, go ahead.
Um, I see that on Canvas, we have a different PowerPoint than the one on lecture. Should we only focus for studying for the quiz on this PowerPoint in lecture, or because the other one has like I think 100 more slides.
Yeah, that's the publisher's PowerPoints from the textbook. So the chapter that you're reading, those PowerPoints coincide with the whole chapter. If I was to give you a quiz on that whole thing, you guys would kill me. So I
Okay, so
I'm able to pick out what I feel after 30 years of, being in radiology, what are common terminology, pathology that students will see, and to create my quizzes with that common pathology. So I'll focus my lectures on the quizzes. But of course,
okay.
if you want a full knowledge of pathology, you would want to read the chapter, review the PowerPoints for that.
Okay. So this one is the best one to study for the quiz, right?
Yeah, yeah,
Thank you so much.
yeah. Make sure on your discussion board this week that you are citing your sources. So in your post, you'll do your in-text citation, and then at the end of the post, on the bottom of the page, you'll do your reference. Uh, if you go into the course intro module, you'll see the APA formatting for that textbook. So make sure you do that correctly, because if there's no in-text citation, and if it's not done correctly, same thing with the reference. If there's no reference or if it's not done correctly, then you will lose points for that. And that's not something you want to lose points for. Remember what I said, save your loss of points for hard things like quizzes and exams. You know, if the APA formatting is already given to you in that module there, I forgot what that first module is before week one, course intro or something, labeled something like that. Um, I break down that textbook for you. Make sure you're formatting it correctly so you don't lose points. Okay, and then of course, replying to two other classmates as well. Any questions with this lecture with skeletal or week two? Okay, and like I said last week, if this is still pretty broad, as far as skeletal is pretty broad as far as like, hey, focus on this for the boards. Uh, Nothing here I would also give you additional information for board review on yet. As we get into respiratory GI, we will have things to talk about, like, hey, they're going to be asking you about this on the boards when we hit those systems. Okay. Skeletal, like I said, those common fractures that I put in, yes, those could easily be on the boards. The collies, the boxers, um, and then type of fractures, you may see one or two questions about that, making sure, you have a general knowledge of your types of fractures. What does, an open fracture mean type of thing. So some terminology here, like I said, that battered child syndrome, the SNAT will be on there. So, pay attention to these things. Make sure you don't lose your knowledge of fractures and types of fracture terminology so that you are ready for the boards when it comes to that. Okay, but nothing pretty heavy here on additional things I could give you for board prep besides what's in there for the fractures. Okay. All right. So if no other questions, go ahead and oh, I'm sorry. Yes, bone spurs are really just little pieces of bone, that have split. So it is different from osteochondroma. Okay. Yeah, sometimes they have like a spine as in like a scoliosis patient, osteogenesis imperfecta. Yes. The study guide for the quiz is my lecture PowerPoints. So I see a couple of you asked for the study guide. Just like last week, the PowerPoints should have been helpful for you. For the quiz, did you feel the PowerPoints from last week's lecture were helpful for the week one quiz? Okay, yeah, I noticed the scores were pretty decent, so I feel confident with that. Same thing for this week's quiz. Um, this is your study guide, this lecture. It'll be recorded, so you'll be able to review these PowerPoints again, um, to get yourself ready for the quiz. Okay, if you have no other questions, then I will sign off here. And like I said, type your name in the chat. I'll have the recording by tomorrow so that you'll be able to get yourself ready for the quiz at the end of the week. All righty, and have a good night, everyone.
You have a good night too. Thank you.
Thank you.